without further ado, let me briefly introduce our keynote speaker. I could wax lyrical, I could go on for a long time. You've probably read the bio. If you haven't, that's on you, not me. But I'll just pick a couple of sentences from it to introduce Dr. Leo Russell, a clinical psychologist, although he informs me not a neuropsychologist, and I had news for him last night. Have you ever heard of a counselling neuropsychologist? And he's a specialist advisor in psychology for functional symptoms at Devon Partnership NHS Trust. And he led, quite impressively, the development of a dedicated psychology service and multidisciplinary pathway for functional neurological disorder, FND. Sometimes described as niche, but actually it's pretty much what I feel, and I'll argue, led to the genesis of our profession back in the Freudian years, and, emerging from a neurological discipline into what was perhaps originally psychiatry, but ultimately psychology and a bit of both. The talking method for medically unexplained symptoms, depending on which kind of route into the healthcare system that you might access it from, somatoform, and other nomenclature too, which I won't bore you with in this moment at least. Besides that, I had the pleasure of having dinner with him yesterday. He hadn't been informed of that plan, and I can only but apologise for his tolerance, or at least praise him for his tolerance of me. But it was an interesting conversation, certainly for me, and I learned that he's also a family man. He's a very tall man, and I don't think there's anyone here taller than him, as you'll see. But he's incredibly passionate and knowledgeable and expert in the area that he works within. And he has the respect of myself and many others, particularly the context for this, which I'll try to wrap up very concisely. Again, no promises, but don't follow through on them. The Division of Neuropsychology have done sterling work in recent years. They really have. They've sort of stood out, and there's always cycles with divisions and SIGs who do sterling work, and it just, it's hard to maintain and sustain that. But in recent years, the Division of Neuropsychology have published and launched frameworks that are groundbreaking, progressive. There are key personnel in the room that I think share a lot of the credit and kudos for that. Fionnit, Sarah, Garrett, Tom, Valerie, and others, Teresa in the back, founding members who I'm delighted to see in the room as well today to share this experience with. And it ultimately is a Division of Neuropsychology initiative or event and keynote invitation. We don't typically have 3, we generally have 2, so even that is a bit standoutish, but it's appropriate. 16 years of existence is what the division is now celebrating, although they possibly existed as a SIG prior to that, but we will shh. And Sweet 16, it ruins the Sweet 16 thing if we get into the weeds of that. But I do just want to put a little emphasis on the efforts and input behind the scenes over many, many months of Sarah Casey, Dr. Sarah Casey, who really made this happen. So just to acknowledge that. But it's time for me to shut up and leave the stage. And without further ado, I might welcome to the stage the wonderful, the many, many different descriptions I could possibly get into, Dr. Leo Russell.
Okay. So thanks very much, Damien, for that kind introduction and for outing me as not a neuropsychologist. And thanks also to yourself and to Sarah Casey and the committee for the invitation to join you all here at this conference. I appreciate this is actually a very precious time together, and so it's a real honor for me to be here and to steal some of your time today. So I'm a clinical psychologist, although I work in a neuropsychology department, which is part of a mental health trust. My role there has been as clinical lead for the FND psychology service, and also as chair for the MDT pathway that oversees the FND pathway, across mental health and physical healthcare services. So I've been in that role sort of 8 years or so, and then in July last year I stepped down from that and now serving more as an advisor to the Trust on Psychology for Functional Symptoms. So I wear 2 more hats. One is as as director for ISTDP Health, which are a training organisation in ISTDP, But probably my most privileged role is as ambassador for the FND charity, Experts by Experience charity, FND Friends. So they're based in the southwest of the UK, and they do terrific work raising the profile of FND, and they helped us a lot in our particular part of the southwest in Devon in developing services. So I'm going to start today. I know many of you will already be familiar with FND, but just for those of you who may be less familiar, FND really is it's an umbrella term that describes a heterogeneous group of functional conditions that present in the neurology medical speciality. So it's a variety of neurological symptoms that you'll see here, which includes functional seizures, disordered movement, paralysis, weakness, cognitive impairment of some kind or another, and speech disorders. So FND can look very different from one person to the next. A key characteristic, but by no means the key characteristic of FND, is that these symptoms appear in the absence of structural brain disease or brain damage of any kind. So what this means is that these symptoms come about from a much more complex relationship between the mind and the body. We consider it more of a brain network issue than an organic issue. Although what you might detect as I stumble across my words in this presentation is that even the terms organic and functional aren't really quite adequate for understanding the mind and the body relationship. Another key thing about FND is that it's very prevalent amongst the neurology population. So it's the second most common presentation to outpatient neurology. The first most common presentation is headaches and migraines. So a proportion of those will also be functional. So it's a large group of folks with FND. But also, this is a group of folks who suffer significantly. So when you compare the quality of life for folks who have FND symptoms to peers who have symptoms from traditionally organic conditions, what you see is that the folks with FND report poorer quality of life. And another sad thing when thinking about historically working with folks with FND is that we've had pretty poor prognosis. So one study by John Stone and colleagues found that the majority of people with FND were still reporting symptoms 12 years after diagnosis. And we think that we're getting better at treatment, so there is reason to be hopeful and encouraged. But I say this just really paint the picture that for quite a long time, folks with FND have been somewhat neglected by services. I wanted to start the presentation with the voice of someone who's actually an expert by experience with FND. So this is my friend and colleague, Mandy Hall, who is the chair for FND Friends. And I said to her, look, I'm going to this conference in Ireland to speak with lots of lovely psychologists, and I'm really nervous. But I want you to be able to say a little bit to them about what's important to you from your experience as someone with FND, what would be helpful for them to know. So this is what she shared with me.
Hi, I'm Mandy. I have FND. I've been living with FND for over 7 years, and I am a current volunteer and trustee for South West Regional Charity FND Friends. FND has been really tough. Before my diagnosis, I had been working in the healthcare industry for over 20 years. I was a full-time mum. I still am a full-time mum, and really, really busy, very active, on the go all the time, never diagnosed with depression or anything. So being given a FND diagnosis and also all of my symptoms as well. Let's say I was dealt a bad card of FND. FND is very much like living a long version of the childhood game of Simon Says. Yet Simon never says stop. the more you fight it, the worse it gets. And to think that, you know, any form of stress, mental or physical, is causing it, you just can't stop it, and Simon just keeps telling you what to do. It's really, really hard. So for a professional's perspective, to be able to talk to patients more and understand what we're going through, you need to put yourself in their position. I was always brought up to treat people as you wish to be treated. Don't judge. You know, don't assume that we all have mental issues, but maybe how FND is affecting our mental health. We just ask for patience, caring, understanding, and somebody to listen. That's all we need. But again, thank you. We need your support to keep just to keep educating others about FND as well. But always, like I said, don't judge. We had a young woman who was told that her symptoms were a TikTok trend. That's not the case. And really, that person, that doctor, that professional should not have said that to her. Unfortunately, that young lady took her own life. And that's the worst outcome for everybody. So please, 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 be kind, be caring, be considerate. Think of how would you like to be treated if you was a patient. Thank you.
Okay, so it's a very sobering reminder at the end of the importance of really listening to our patients and their experience. Okay, so to the title of the presentation, we're speaking about how we can move from disconnection to integration in FND. So begs the question, what's disconnected and what are we trying to integrate? Well, in the first part of the presentation here, I'm going to focus on the systems of care for people with FND, different stakeholders involved in FND support, and how we can look to connecting these up. And I'll be speaking about the way we developed a pathway locally, but hopefully you will find the ideas are relevant if you're working with an individual who has an FND diagnosis, to think about who you might want to bring into that person's care. And then in the second part of the presentation, I'm going to go more into the micro and the individual with FND, and we're going to look at how emotion processing can be disconnected, if you like, and how we can integrate this for some folks with FND. And then hopefully throughout the presentation, I'll be speaking to both implicitly and explicitly how your core professional skills, which in your mind may not yet be linked up with FND, how we can link these up so you can see that you already have many of the skills and competencies that you require in order to support people with FND. So that's my plan. So I'd like to say that connecting up the different stakeholders in FND is a straightforward process, and I'll give you a series of steps and then you can go off and do that, but of course that's not the case. Because everywhere where we work, we're all in different settings, so the different settings have different characteristics, different demographics, different services, different groups of professionals. And so realistically, it looks more like this. You're this person stood here, you're thinking about how to connect up the next bit, and the person who's best placed to know which bit to go next, which steps to take, is going to be you. Because you will know which doors are easiest to push, you'll know where the blocks are. Fortunately, the context in Ireland, I think it's a very exciting time for FND over here. There's been lots of development. There's a fantastic article in the recent issue of the Irish Psychologist, which Sarah Casey wrote, shining a spotlight on FND. In October, there was also the inaugural conference on FND with FND Ireland, and I believe there were over 200 people in attendance there, and a number of your esteemed colleagues here presented, which was very well received. FND has also been recognised as a care population of need in the HSE National Service Care Plan for this year. So you've got another month to really fit this in. And as a result of the work of some of you here and of FND Ireland and the Neurological Alliance, funding has also been secured for a specialist service at St James's Hospital, which I understand will have a consultation piece that's available nationally, if I understood that correctly. So lots of development. There's good existing networks, folks with experience that you can link into if you're wondering what you can do locally. So I'm going to describe the process of how we developed the pathway in Exeter. I do this here, again, not as a prescription to say this is how you should do it, but maybe just to share some ideas about different ways we approached trying to bring together some of the systems of care. I should, just to give you a picture, I should say that Exeter is part of Devon, which is in the southwest of England. It's in quite a rural county, about 900,000 people in the county. The story from my perspective starts from being in the neuropsychology service. So, in fact, just before I joined, there was an audit of the referrals that were coming into neuropsychology, and they found that 40% of the referrals were already for people with FND symptoms of one kind or another. So they decided to dedicate an existing resource to FND. So this is when I joined along with my colleague, Dr. Rachel Carrick there. Both of us from mental health backgrounds, both of us not neuropsychologists. And this may have shaped the way we approached FND to begin with. But one of the things that we really discovered was that it was critical to work with our colleagues in rehabilitation and neurorehabilitation services. So we developed good links with our neurophysio and occupational therapy colleagues, developed a shared language, explored some initiatives together, and did some co-working. And this was a really important educational experience, I think, for all of us as we were just working out what can help people with FND. And then we went on from this. We realized we needed to find some more people who were also interested in working with FND. We were really too small a core. And so we decided to do a conference in our local healthcare trust, which we invited folks along to, where we shared about what we'd been doing. FND Friends had just been formed at that point as well, so we invited them along, and they gave a really great presentation. And this was also a terrific opportunity to network. And what came out of this was a core group of interdisciplinary colleagues who were interested in improving care for FND. So this included consultant liaison psychiatry, included speech and language therapy, inpatient psychology, and also, crucially, neurology itself. Later on, we also added social care, and we added nursing, with a specialist epilepsy nurse who joined the team. And we gradually formed a multidisciplinary team. And in fact, we benefited in a strange way from the consequences of COVID, which was suddenly we had a way in which we could meet virtually. Prior to that, we were unable to find a room where we could all meet at the same time. So MS teams came to the rescue, and over time we developed a pathway that's across the mental health and the physical health service. And the final step of this was that we branched out even further, and we were hearing from colleagues in neighboring trusts about what they were doing. They were interested in what we were doing. So we developed a Southwest regional network, where again we met virtually twice a year just to share our experiences together, which has been tremendously grounding, I would say. Okay, so what do we come up with? How does it look? Well, I would say there are two main, two core things about the Exeter model. The first thing is that we saw the assessment and treatment of FND as necessarily a multidisciplinary task. So we needed the different disciplines involved, so we had the range of skills required to support people with FND. But this also meant that we could capture patients presenting in different parts of the system, the healthcare system and beyond. We could develop coherent care plans that were written in the same language, and we could disseminate the full range of expertise across professional groups and across the services and hospitals and community services where we worked. The second key feature of what we developed was that we saw FND as part of the core business of the acute and community services. Now, this was again partly a necessity. We were in a difficult financial climate. There was no way we were going to get any additional funding at this time. But mainly it's because we saw that all our services already had folks coming along who had FND symptoms. So we recognized that it was going to be a more anti-fragile system, a stronger system, if we saw patients with FND within the services that already existed. So this is what we came up with. This is what it looks like right now, but maybe in 5 years' time we'll discover there's a different way of doing it. It starts with the patient presenting with neurological symptoms, query functional neurological symptoms. It will be either to their GP or the emergency department, or it might happen during admission of some kind. And the first important step that we did in terms of the pathway was we said that all patients with FND query must have a thorough neurology assessment and diagnostic process. So this isn't a neurologist having a 5-minute conversation with them whilst they're on an inpatient ward. This is an extensive assessment. And there are 3 reasons for this. One is that, as I said, it's important to identify that there are no other differential diagnoses, so the patient has an experience of other possibilities being considered, and that they understand why these other possibilities have been excluded. But FND isn't only a diagnosis of exclusion, it's also a positive diagnosis. So neurologists are looking for a positive profile of FND, specific phenomena, which shows them that this person matches the criteria for FND. And the third important thing that neurologists learned to do was that they would help the patient understand what the diagnosis meant, help them understand that it was a medical diagnosis, but the treatment was either rehabilitation or psychology approaches. So this really helped patients to have more buy-in to the treatment process. I've mentioned the multidisciplinary team meeting already. There were 2 parts to this. In the first part, we invited people along for consultation, and we would discuss specific cases, and we would identify where there were difficulties, where we needed to improve the pathway. We developed care plans jointly. And this also fed into the second part of the meeting, which was a business meeting, where we discussed the pathway itself, and we looked at how we could improve it and what sort of initiatives we could explore to raise the profile of FND. So the community treatment pathway itself, as I say, it's involved community rehabilitation, so physio or OT or speech and language therapy, or FND psychology. Now, if we were a specialist service, it would be ideal if we could work in an interdisciplinary way, so the patients could arrive, we could do our assessment together. I mean, that's the ideal, I would say. But we had to cut our cloth accordingly. We wouldn't have got the remit to do that from our managers. So we decided to do a frontline, second-line approach. So for psychology, we were seen as the frontline approach for functional seizures. Now, in the end, we saw about 50% of our patients were primarily patients with functional seizures. So we were still seeing the other patients, but only when they'd had physio or OT and psychological factors had been identified, or they'd got stuck in some way or another. And then in terms of the treatment with psychology FND service, it involved a lot of the core skills that you will all use. So it had assessment and formulation. We would do 1 to 2 sessions of this to try and understand what was happening for that person, how it came about. Then some folks would go on to do a brief intervention, which might be anxiety management, emotion regulation, behavioral activation. Some folks would go on to have consultation, So we might do some systemic liaison work, either with their family or carers or other parts of the system. And then about 60% of patients would go on to do psychotherapy with us, and we had a few options around psychotherapy. That would be EMDR, ISTDP, which I'll talk about in a moment, compassion-focused approaches. And then for some patients, we would use a more light touch approach, perhaps because they weren't suitable for psychotherapy, or because we felt that a light touch approach would be enough for that person, which was an online program that combined key ideas from general psychoeducation for FND, but also mindfulness and acceptance and commitment therapy. So it's important, obviously, when you develop something to try and measure if actually it's doing the thing that you hope it's doing. So that's important, but also, as you all know in your services, it's important that you've got data so you can demonstrate to your managers and to those decision makers why they should continue to support you in what you're doing. So I'm not going to go into this in depth now, but just to highlight there are a variety of ways that you can do this. So one way is through looking at symptom outcomes. So we did a case series of our psychotherapy arm, which showed that people had significant improvements, not just in well-being and quality of life, but in the functional symptoms themselves. But we also did a couple of health economic studies, looking at some single cases. So one case, we found savings for the ambulance trust alone of over £30,000 in 1 year. So that's one case. But another thing you can do is you can look at reducing bed days, or what we did was prevention of admission. And we found that we identified 12 patients at high risk of admission. Some of them were already on the waiting list to be admitted to inpatient neuro rehab. And with some community output, none of them were admitted. So we were able to demonstrate significant savings from that as well. Okay. Is this all following so far? Yeah? Good. So I wanted to share a few reflections on this experience. First of all, hopefully what you can see is the importance of working across professional disciplines, but also across healthcare boundaries and community inpatient services and so on. And that this can be strengthened when you do this in collaboration with FND patient advocates, because they will be the people who know where the gaps are, because they will have experienced it personally. 2, tell people what you're doing. Now, it can be a bit nerve-wracking. When we started this, I would say I had very little idea what I was doing. I think now I have a lot more idea. There's still a long way to go. But it's important, even though you might not be confident, to let people know what you're trying to do and how you're trying to do it. And one way of doing this is to give it a name. So I was sort of stunned by the impact, but when we just called our group the FND MDT complex case group, how suddenly we were a thing, and this raised our profile and people would get in touch with us. So give what you're doing a name and start before you know what it will look like. Listen to patients. As I've said, they're the folks who will know where the gaps are, where the recurring problems are. There may be particular colleagues in that broader healthcare service where you keep on hearing things being said where you might need to have a conversation with that colleague. So patients will usually know. And rely on your core psychology training. So you've got all the core skills from assessment, formulation, building a therapeutic alliance, systemic work. I suspect what you'll find, if you haven't found already, is that you know more than you realize when it comes to working with FND. One of the things that we found was that it was really important to challenge stigma and outdated ideas. There's a whole lot of mythology out there around FND, unfortunately. And so I guess one of my mantras over the past 8 years, in part to patients, but mainly to other healthcare staff, and particularly maybe the more old school healthcare staff, is to say FND is real. It's not the person's fault. This is really happening in their body, and It's not behavioral. That's the other thing you hear a lot of. And people can get better as well. These symptoms can improve. So it's important to just repeat these messages and make sure they're heard. Now, there are a few other ways that stigma and discrimination affect the FND population. One of these is that we have a greater number of people who have FND also have neurodiversity, one kind or another. So it's important that you consider how to make your services accessible to folks who have neurodiversity so that you don't create barriers to treatment for that particular group. And a third thing I mentioned is that patients with FND can suffer discrimination because there's a greater proportion of people with FND are women. And so they face a lot of the discrimination in healthcare that happens towards women. Now, as a middle-aged man, I'm not going to expand on this myself here. You don't need to hear from another one of them. But I will point you towards this excellent paper, Functional Neurological Disorder is a Feminist Issue, by Kiva McLaughlin and 45 other leaders in the field of FND who are women. It's a terrific paper. I'll put a link on it to this at the end, which you'll be able to follow. And finally, our advice would be don't wait until you've secured funding before working together to help folks with FND. So it's really important, of course, to do business cases, to build a picture, to try and advocate for funding. But we all know sometimes that means you can be waiting, well, your whole career sometimes, for things to come about. Folks with FND are already in your services, so you can already do something to start to help folks before funding is secured. And here are just a couple of extra resources. Again, I've got some links to these for you at the end, which weren't available when we started our work. And just to highlight the BPS Neuropsychology and Psychological Management in Children and Adults paper that came out last year. This is a really good summary of the state of the evidence on theories and treatment for FND and on the different roles of psychologists in this. Okay. So we're going to move on to part 2. We're going to the individual, and we're going to think about emotion processing and how this is relevant for some people with FND. Now, I want to highlight that there are multiple different causes for FND. We don't know all the causes for FND. Some of the causes we do know have been identified in this nice review paper by Drain et al. Emotion processing, agency, attention, interoception, predictive processing. And we're going to focus on one of these today, which is emotion processing. And we're going to do this through the lens of intensive short-term dynamic psychotherapy, ISTDP, the short-term therapy with a long-term name. And in particular here, what I'll speak about will be very influenced by the work of Alan Abbas and his colleagues who've been using ISTDP in public healthcare system in Nova Scotia in Canada for many years. Hopefully what you'll see is, although we're focusing on emotion processing, we might get in some sneaky stuff on agency, attention, interoception, and predictive processing too. Okay, so why should we be interested in emotion processing in FND? Well, the first point here is that trauma, adversity, chronic stress, emotional neglect are common within the FND population. Which is to say, again, not everyone who has FND has these features, but it's more common than non-clinical populations. And in fact, the majority of patients who present with FND have had a severe life stressor, severe life event prior to the onset of the FND itself. And interestingly, one study by Tim Nicholson and colleagues in London found that 88% of the severe life events were not reported or discovered through routine assessment. Which is kind of interesting, and there may be two reasons for this, at least. One is that maybe we don't ask the right questions in routine assessment. But maybe also folks who have emotion processing deficits are less likely to report severe life events. So there was a really excellent paper here that helps us to think about how this association between FND symptoms and adversity, trauma, neglect can come about. This is a paper by Susanna Pick, Laura Goldstein, David Perez, Tim Nicholson on emotion processing in FND. And they found two particular types of emotion processing were common. I'll start again. Two particular types of emotion processing deficits were common. The first were deficits in top-down processing, so the ability to think, reflect, mentalize on emotions. And the second was deficits in bottom-up processing, the ability to experience and express emotions. And this is what makes short-term psychodynamic therapies a good candidate for the treatment of FND, because these therapies have particular methods for addressing both top-down and bottom-up processing. And intensive short-term dynamic psychotherapy is an evidence-based approach to working with functional symptoms and FND, which focuses specifically on top-down processing and bottom-up processing, and knowing when to move between the two. And this is why I'll be speaking about this today. My hope is that you will see how some of these ideas bridge with the ways in which you already work. Ideas you use from other therapies. You can see there'll be some similarities that hopefully you may find useful to you. So this is just some data here for a meta-analysis on short-term psychodynamic therapies for functional disorders. 11 of these RCTs were for ISTDP, and we found there was significant improvement in well-being and quality of life, and again, in the functional symptoms themselves. There were four case series studies, so smaller studies into ISTDP for FND, which showed the same trends of improvement in well-being, quality of life, and functional symptoms. We've actually had a proliferation of studies since this time, so there are now 35 RCTs on ISTDP for functional disorders. And this evidence, along with evidence from other colleagues, led Richard Brown and Miles Gutkin in their review of psychotherapy for FND to conclude that alongside CBT, that short-term psychodynamic therapies are the primary psychotherapy approach, that these two together should be two psychotherapy methods we should be considering for FND. Okay. This is all making sense. So if we're looking at FND through the lens of ISTDP around emotion processing, it's important to think about how this might make sense. How is it that emotion processing deficits could lead to symptoms? So when it comes to emotions, one of the curious things is there's no universal consensus in our profession on theories of emotion. Right? We do have a number of very good theories, but no consensus. So along with my colleague, Dr. Alan Abbas, and the neurologist, Steve Alder, we thought together about some of the emotional systems that are involved in feelings in the brain. So we have them here. The first system here, the bottom feeling systems, is the bottom-up processing of feelings. Now this involves particularly the brainstem, the reticular activating system, and here we have emotions hardwired into the brain and body from birth to act as unconditioned stimulus to guide our behavior in ways which is adaptive in the context of our attachment. So for example, the grief-panic system is a system which is mobilized when we're separated from our caregiver or facing potential separation. This is an aversive feeling. It's not very pleasant, so the infant will immediately resist separation without knowing why it's doing it. It's just unpleasant. But should the separation occur, then this will mobilize the action tendency of the grief-panic system, which is to cry. And the infant who cries, that will then mobilize the attuned parent's feeling system, and then that parent will go to that child in an attuned and timely way to meet their needs and help them to co-regulate their emotions. So that's the first system. The second system here is the conditioned response system. So this involves areas of the midbrain, the basal ganglia, the amygdala, which are involved in patterning responses to the world. So how does the world respond to you? And then you learn automatic habits and physical responses that are adaptive. And then we have the third system here, which is top-down processing of emotions, which are the construction systems. So these are your higher cortical capacities, your language capacity, and so on, which helps you to regulate down, or can escalate up, your experience of emotions, and also gives your emotions different shades and different varieties. So I mentioned the case of what happens with the attuned parental experience here, but what about when the parent responds to the child's emotional responses with rejection, withdrawal, or harm? So now it's no longer adaptive for that child to express their emotions. So we need another system that is more powerful than emotions, that can trump the experience of the emotions. And this system is the threat response system, is anxiety. At a certain point of anxiety being mobilized, you can no longer experience the feelings underneath. So it keeps them out of awareness, literally. But it's not very nice feeling anxious either. So we also stumble across behaviors that ameliorate the anxiety, and as such, incidentally, also keep the feelings further out of awareness. So imagine the child who experiences grief or rage or love and is expressing this to the parent withdraws or rejects or harms them. Then this child becomes anxious, but then maybe they learn to focus on others or to get really busy, right? And so now, whenever their feelings are mobilized, they just get busy and focus on others. They don't know they're doing it, they don't realize they're doing it, it's just part of their identity. So if you're a cognitive therapist, you might call these habits safety behaviors. If you're an analyst, you might call them defenses. But feeling becomes conditioned with anxiety and defenses, and this itself may never be a problem, unless something happens later in life which creates a bigger dose of feelings or compromises the defenses. So imagine maybe the person loses a parent. Maybe they go through divorce. Maybe their child leaves home. Maybe they fall in love, creating a bigger dose of feelings, because what's going to happen then? You'll get more anxiety in the system if you have more feelings mobilized. Alternatively, let's say the person who learned to keep busy and focus on others, let's say they trained to become a psychologist. And this is a very good way of being busy and focusing on others. But then, at some point, they have to have a medical procedure, and this means they're bedbound for 2 weeks. And all of a sudden, they can't keep busy and focus on others. Now what's going to happen is the feelings are going to start, unprocessed feelings are going to start to come to the surface, and then we'll get massive anxiety. So a big question when it comes to functional symptoms is, how does this anxiety appear in the body? What is it in the body? And there are some different routes it can go. So, and you'll be familiar with some of this. So the first place anxiety can go is into the fight-flight response. So you get increased heart rate, more adrenaline, and you get tension in your striated muscles. So these are your voluntary muscles, beginning in your hands, your arms, your neck, back of your head. Then your intercostal muscles, down into your abdomen, down into your legs and your feet. So if your feet are all tensed up, you know that you're anxious from head to toe, because this is the last place it shows up. So you get striated muscle tension. Now this is helpful in the face of temporary danger. Let's say you go to step into the road, you see a car coming, you get a big dose of adrenaline, this gives you tension in your striated muscles, you jump out of the road, the car goes past, and you can rest, your body goes back to relax, your muscles no longer tense. Okay, that's adaptive. But if the danger that's triggering your striated muscle tension are the unprocessed feelings, which aren't going anywhere, then you're going to end up with chronic tension in your striated muscles. So imagine this now. You're all tensed up all day. Right? This is going to have physical consequences. It's going to lead to pain. It's going to lead to aches. It's going to lead to tiredness. So this is why some people who have functional pain disorders and fatigue, that it can be caused in this way. Again, not all people, but some people. But we have a second level of anxiety, which is smooth muscle activation. So here you can get acute and chronic spasm of the bladder, the blood vessels, the airways, the digestive tracts. And this, again, has physical consequences. It can cause nausea, sickness, diarrhea, constipation, It can cause bladder spasm, it can cause acid reflux, a whole variety of physical responses. And again, if this is being chronically activated by unprocessed feelings, then this can lead to, for some people, functional gastrointestinal disorders and functional migraines because of the effect on vascular functioning, because of the involvement of blood vessels. Now, some of you may have cats, and your cat might love you so much that occasionally it brings you a present home. And if it really loves you, the present it brings home will still be alive. So all of a sudden, you have this mouse on your kitchen floor. And the mouse is running around. It thinks it can escape from the cat. And at this point, its striated muscle tension is activated because there's danger, but it can do something about it. But if it becomes more perilous for the mouse, if the cat's getting closer and closer, what the mouse might do is he might poop himself. Okay? So this is its smooth muscle system. It's adaptive. It makes it less attractive to the cat. But it doesn't work. And eventually the cat catches the mouse, and now the mouse is in the cat's mouth. What's the mouse going to do? It's going to play dead. Yeah, it's going to play dead. Now, this isn't sort of an acting performance. This isn't the Paul Mescal of mice. This is a physiological response in the body. What's happening is the mouse is getting a loss of muscle tone, it's getting weakness, paralysis, numbing, and these are physiological responses linked with more extreme parasympathetic activity, which we call conversion anxiety. And then at a higher level of anxiety, you can get cognitive perceptual disruption, which is where you're not getting enough oxygen for the brain to function optimally, so you can experience confusion, difficulty concentrating, difficulty focusing, you can get distorted vision, interrupted other perceptual experiences, hearing and so on. And at the higher end of this, you can get dissociation, and at the top, you can actually lose consciousness. So it's these two anxiety pathways which we find for some people with FND are associated with these conditions. So to summarize, feelings, which are hardwired into the brain and body from birth, can become conditioned with anxiety and defenses. If later in life you get a bigger dose of feelings or immobilization of the defenses, it can cause anxiety. And the pathway of anxiety reflects the degree of adversity in the initial trauma. The greater the adversity, the more severe the pathway. And the type of pathway can cause particular kinds of functional symptoms. So what we try to do in ISTDP is we try to first of all get the anxiety down. So we use top-down processing to move anxiety down out of cognitive perceptual disruption and into more healthy, striated muscle tension. And then at that point, we can move to bottom-up processing and we can focus on the experience of feelings to decouple the feelings from the anxiety. Simple. Okay. I'm going to speed up a little bit because of time here. So it's very important that we don't assume just because someone has functional symptoms and past adversity that these two things are linked for that person. So one thing you can do is what we call the emotion-focused interview. So here we take a recent event with emotional valence and you press towards feeling and you see if anxiety turns up in the pathway that's associated with their symptoms. So let's say the person you're working with has told you they had an argument with their boss during the week, and the symptoms they experience are migraines. So what we're looking for is when you press on feelings, how do you feel towards your boss for the argument? Do they get anxiety in the smooth muscle pathway that's associated with migraines? So do they get acid reflux? Do they go nauseous? Do they feel dizzy or feel sick? Do they need to go to the loo? And then if you find this relationship, you say, okay, there could be a connection here. Should we see if we can work together on a piece of therapy to see if we can make a difference? So I'm going to share a vignette now. And this is just a quick note to say, well, the patients have given their consent for the vignettes to be shared, which is extremely generous of them. But obviously, this is on the basis of treating it with confidentiality. So no recording of audio or video of any of this piece here. And if you happen to know the person, which is unlikely, then just excuse yourself for 15 minutes, and then if you could come back, that would be great. To make potential links between her symptoms and anxiety that's coming up just here with us focusing on her. So once you've found something that may be a relationship, you decide that you might work together, what's the first task? So the first task is this top-down processing piece. So you're trying to build reflective capacity. So patients with emotion processing deficits will often ignore or neglect their inner experience. Okay, this is a defense or a habit. Interrupting this habit is going to cause anxiety, because underneath the defense is anxiety. And in patients with FND, where this is a factor, the anxiety will be in the form of cognitive perceptual disruption or conversion anxiety. So the task is to use cognitive reflection to strengthen interoception and build capacity. This augments the anxiety out of the unhealthy pathways and into striated muscle tension. So in summary, address neglect of inner experience and build reflective capacity. Those of you who work in psychodynamic ways will be familiar with the triangle of conflict. This is really what I'm describing. That feeling gets conditioned with anxiety and defense. When you address the defense of ignoring and neglect, underneath will be the anxiety. And that this experience was learned early on, but this pattern will happen with current figures. That's how the symptoms are turned up in their life, but also it's going to happen in the room with you. So in this next vignette, I'm going to share, this is a person who had functional seizures. In the conversation up to this point, we've talked about how her functional seizures appear, what happens for her. We've learned that they started after she had a period of, she'd actually suffered with diarrhea, she had some kind of bug, she was neglecting herself so she wasn't hydrating, and then she collapsed. And then she returned home where her parents-in-law were, who she was expected to care for, and then the symptoms began. And we've also noticed that in our meeting, she's highly anxious, and the anxiety is going into discharging in her leg. And we've noticed that she's ignoring that in the room with me, and she's prioritizing me. So this is where we're trying to address the defense of ignoring and neglect. And if we're effective, we might see the conversion anxiety or cognitive perceptual disruption underneath. Address the defense and anxiety. Interestingly, the past figures show up. One of the features of working in this way is you don't take a history up front. You wait for it to come from the patient when the associated memory networks are available because the defenses are no longer activated. Damien, how am I doing for time? All right, so I have to wrap this up now. Yeah. That's fine. No, that's fine, thanks. I was once at a conference and I was tasked with getting someone to finish and they just wouldn't leave the stage. Okay, I won't be that person. Okay, so I'm just going to very briefly say, at some point here, you switch from top-down processing to bottom-up processing. And this is the point when you've augmented the anxiety into the healthy pathway, and now you can press towards feelings. And these core feelings, at least, they all go upwards and outwards. So grief, for example, is upwards and a pressure behind the eyes and the impulse to cry. So this is what you're looking for to help them experience their emotions. We're going to skip through the next vignettes, so we still have some time, so we might need to stop recording a second. In fact, all of us hold mixed feelings towards our early attachment figures, but when we haven't had attuned care, we haven't had a chance to process these mixed feelings. So for folks with these maladaptive emotion processing difficulties, once they can mentalize and their anxiety is in striated muscle tension, now you can help them to experience the full range of their feelings. And this decouples the anxiety from the feelings, which helps address the symptoms. And the evidence shows us that this is crucial in therapy. So final conclusions are that for some people, FND may be linked to emotion processing difficulties, which may be linked to early experiences and how feeling, anxiety, and defense got connected. And the literal pathways of anxiety can cause functional symptoms of one kind or another. So our task is to support patients to notice, reflect on, and mentalize their experiences, first of all, to build capacity, and then to help them face and experience their mixed feelings. So these are no longer tied to anxiety and symptoms. And this brings me to the end. There are slides available from the, if you scan that QR code, I think it's called. But thanks so much for your time today. It's been a real pleasure talking with you all.